Hello. So today we are going to discuss jaundice neonatrum for the final year, and I have used pervez akbar as a reference. So jaundice is a symptom, not a disease. It is seen in daylight, and normal bilirubin level in the blood is 0.2 to 1 mg per dl, and visible jaundice occurs when the level is 5 to 7 mg per dl or greater than that. Hyperbilirubinemia in neonates can be due to unconjugated bilirubin or conjugated bilirubin. So for the unconjugated bilirubin, we have the mnemonic unconjugated, indirect, insoluble in water, and more dangerous. All are long words: unconjugated, indirect, and insoluble. Whereas conjugated is direct bilirubin and water soluble, all are short words. So the unconjugated bilirubin normal value is 0.2 to 0.6. It is indirect, insoluble in water, so fat soluble, pathological or physiological. So as it is fat soluble, it can cross blood-brain barrier, and high concentrations of the unconjugated bilirubin leads to kernicterus, as there is no albumin bound bilirubin here, unconjugated bilirubin. So binds in albumin, so it is safe. If it binds to albumin, it is safe. For conjugated, it is direct, soluble in water, and this is always pathological, whereas unconjugated bilirubin can be physiological as well. Next is bilirubin metabolism, and this is the summary of pathway. If you want to see the whole video, it is uploaded. And the reasons why the jaundice occurs in neonate is because it has high concentration of hemoglobin, and hemoglobin F, which is in the fetus, is not stable in high oxygen environment. 1 gram of hemoglobin breaks down to 34 milligram of bilirubin, and neonate has low conjugating enzyme. UDP enzyme is the conjugated enzyme. It is here in the step, which is in the liver, and for that we can give phenobarbital, which is liver enzyme inducer. Next, we talk about pathological jaundice. It usually occurs in the first day of life, and for the term baby, the value is 12 mg. I have added a mnemonic in the next question. Preterm, we have value 15 mg. Jaundice after 14 days is persistent jaundice. Conjugated bilirubin greater than 2 at any time is pathological jaundice. So these are the 4 criteria for pathological jaundice. Unconjugated hyperbilirubinemia is due to hemolytic or non-hemolytic causes. Hemolytic are discussed in the next section. Non-hemolytic, either breast milk jaundice or other types of jaundice are discussed next. Conjugated hyperbilirubinemia is due to hepatobiliary tract involved, and there are pale stools and dark urine. This is also discussed in biochemistry video, why there are pale stools and dark urine. Causes of bile outflow are biliary atresia and cystic fibrosis due to bile duct. This is very important, biliary atresia. And due to the liver, parenchyma involvement is torch infections, and genetic causes include Dubin-Johnson and Rotor syndrome. Next is physiological jaundice. This occurs in healthy infant after 24 years of age, not before the 24 years. Total bilirubin rises less than 5 mg per dl. Peak bilirubin 3 to 5 days. So the value for term baby is 12. So the first word from T in counting is 2. So add 1 and then 2, then it's 12. For preterm we have P, and P is for penta. So for preterm we have 5. 5 is for penta, so 15 mg per dl. It resolves within 1 to 2 weeks. So classification of jaundice: if jaundice is less than 24 hours or in pounds and soles, then always refer to the hospital. It is pathological jaundice. The reasons I have discussed earlier, that neonate has low liver enzymes and HbF breakdown is happening. Next is hemolytic disease of newborn. So it can be congenital, either spherocytosis and G6PD deficiency, or acquired. For acquired, we have 3 types. First, we start off by discussing Rh incompatibility. So in this, mother always has Rh negative group and fetus has Rh positive group. It is uncommon in first pregnancy, and during the delivery process, mother sensitizes to the fetal blood by placental tear and produces IgG and IgM antibodies. So in next pregnancy, she can have second trimester hemolysis in the fetus, and newborn can have swear anemia, swear jaundice, hydrops fetalis, and death. This is due to negative and positive group difference. There is always Coombs test positive in this Rh incompatibility. Next we have is ABO incompatibility. Direct Coombs test is either positive or negative. ABO incompatibility protects against the Rh incompatibility, as antibodies A and B are destroyed before fetal cell sensitizes Rh antigen. So mother has blood group O, A or B. AB blood group has no incompatibility. Here you can see that mostly in the scenario it is Rh group is same, and there is O blood group of mother, and A or B blood group of the infant. Next is drugs. For drugs, if mother uses sulfonamide, anti-malarial or nitrofurantoin, the baby can have G6PD deficiency and hemolytic anemia. Next, we start off by evaluation. We press the skin and there is yellow color in the pressure area. We also take family history, maternal history, and infant birth history. And signs of the jaundice. It usually starts from the face and spread to peripheries as the degree of jaundice increases. Jaundice with hepatosplenomegaly and pallor is hemolytic anemia, and jaundice with microcephaly and chorioretinitis can be due to torch infections. In adults, there is a point that for jaundice, we see the sclera like this, and in jaundice, pallor of anemia cannot be determined. Next are investigations of jaundice. So there are 4 basic investigations: serum bilirubin level, CBC and retic count, blood group and mother and baby, and Coombs test. For CBC level, we check the polycythemia. If the hematocrit is increased, it can lead to jaundice. In the hemolytic anemia, we will have low hemoglobin and high retic count. Low hemoglobin due to destruction of RBCs and high retic count due to overproduction of RBCs to compensate that destruction. This is in hemolytic anemia, and in sepsis, we can have low platelets and WBC, and there will be jaundice. Next is blood group. We can have the ABO incompatibility and RH incompatibility as discussed earlier. So the tip for this one is that basic investigations for jaundice are 4 Bs. First B is bilirubin, second B is blood picture plus retic, third B is blood group of mother and infant, and fourth B is Coombs test. You see the B here. Other tests are torch antibody titer, abdominal ultrasound, hydra scan for biliary atresia. This is very important as biliary atresia can lead to conjugated hyperbilirubinemia. G6PD enzyme assays and LFTs. Management for the unconjugated bilirubin methods include phototherapy, exchange transfusion, and pharmacological treatment. Goals are to prevent the kernicterus, which we will discuss later. Next, we will discuss phototherapy, and first are the indications. So indications, we have main word exchange here. So bilirubin 5 mg below the exchange level. In hemolytic disease, wait for the exchange transfusion, after exchange transfusion, and unconjugated bilirubin. Prophylactic, low birth weight, and bruised child. Next is mechanism. Blue light is used, which the wavelength is 420 to 470 nanometer. Toxic unconjugated bilirubin is converted to non-toxic form. Eyes are covered. Devices are either conventional fluorescent lamps or fiber optic, and this is 12 to 24 hours bilirubin monitoring. Duration is until the bilirubin levels are below phototherapy levels. Complications can be overheat, dehydration. For this, we give fluids, rash, and bronze baby syndrome. This usually occurs in baby with conjugated bilirubin, develop dark skin due to phototherapy. So it is only for unconjugated bilirubin. Next, here are the levels. If you want to memorize it, you can screenshot it. So here is the baby in the phototherapy chamber. You can see that. Next is exchange transfusion. For that, indications can be at birth, and we check the cord blood or first week. And the indication here are also Bs, as we have discussed earlier. Bs in the investigation. Now in exchange transfusion, we have Bs. Either bilirubin is 5 mg DL or above, hemoglobin is below 12 mg, Coombs is positive, and retic at above 10% at the birth. In first week, bilirubin at exchange level, low birth weight baby with bilirubin 10 to 15, anemia in the face is progressing, and phototherapy is failing as 1 mg per DL rise even in the presence of phototherapy. Next is site, and we use umbilical vein, umbilical artery, or large peripheral veins, saphenous vein as the site for the exchange transfusion. Complications can be all due to the exchange transfusion that can occur: hyperkalemia, portal vein thrombosis, or air embolism. Next, we have pharmacological treatment, and for that we can use metalloporphyrins intramuscular, which are heme oxygenase inhibitor at the first day as prophylaxis, and immunoglobulins intravenously IVIG for RH or ABO incompatibility. Next is kernicterus, which is due to unconjugated hyperbilirubinemia, and the prevention is usually phototherapy. It is irreversible bilirubin-induced encephalopathy. This affects the basal ganglia, and the acutely baby presents with lethargy, jaundice, poor Moru reflex, and opistotonic posture, which is back arching. Here you can see the back is arching. Normal Moru reflexes, if you see the word Moru, you opposite it, it becomes room. So baby opens the hand when touched at the abdomen, baby creates the room like this. So this is poor in kernicterus. Indirect bilirubin is raised above 20 mg, either it is at 25 to 30. This can cause kernicterus. Convulsions can occur. Death usually occurs in the baby. If it is chronic, it is 2 to 3 years of age, and it presents with mental retardation or extrapyramidal signs, and death usually occurs in this. Follow-up is still school age. Next is breast milk jaundice and breast milk. In breast milk jaundice, you always remember the word milk. So it is due to the milk. as the breast milk of some mothers contain conjugation enzyme inhibitor, so this can cause breast milk jaundice. High bilirubin levels, and these falls 48 hours after stopping the feed, and there is no rebound after again continuing the feed. Next is breastfeeding jaundice. It should be named as not breastfeeding jaundice. So when baby is not fed and due to low breastfeed, the jaundice occurs, treatment is to give the breastfeed. Next is persistent jaundice. It is when the jaundice occurs in baby greater than 2 weeks, and this is pathological jaundice. The important cause for this is hypothyroidism, Down syndrome, galactosemia, Krigler Najjar, and again biliary atresia. If you have any questions, you can ask me. Please don't forget to subscribe the channel and support.